Renal impairment and a multi-system disease. Scenario: a 26-year-old woman presents to the emergency department with several weeks of intermittent pleuritic chest pain and joint pain. She is found to have dipstick proteinuria, a creatinine of 225 moles/L and anemia with fragments on the blood film. Introduction. What is the first priority in a young woman with pleuritic chest pain? The first priority is to establish that the patient does not have pulmonary embolism, PE. Features suggesting a multi-system disorder. Arthralgia, anemia, and impaired renal function all clearly suggest a multi-system disorder. History and examination are crucial in narrowing down the differential diagnosis. Considered analysis of the findings of simple tests such as urinalysis, plasma biochemistry, and hematology will often give a clear lead to the underlying pathology, and is essential in determining the urgency of the situation. Joint and chest pains in a young woman with renal impairment raise a strong clinical suspicion of systemic lupus erythematosus, SLE. History of the presenting problem. Pleuritic chest pain. The differential diagnosis of intermittent pleuritic chest pain going on for some weeks includes PE, musculoskeletal pain, pericarditis, and rarer causes of pleurisy such as autoimmune rheumatic disease. It is clearly very important to pursue the possibility of PE, so ask about previous thromboembolism, leg/calf pain or swelling, breathlessness and hemoptysis. If the patient has musculoskeletal pain, this may be positional. Do any particular movements bring it on? And does getting into any particular position lead to improvement? Pericarditis would be supported by any cardiac radiation of the pain, and also if it were eased on sitting forward. Joints. What is the pattern of joint involvement? Which joints are affected? Is the distribution symmetrical and does this change over time? Is there a diurnal pattern? Is there swelling, stiffness or discoloration? Is the pain eased or worsened by movement? These features are important in the differential diagnosis of arthritis. Renal disease. Until renal impairment is far advanced, it is asymptomatic. Patients with the nephrotic syndrome may notice frothy urine and will, by definition, have edema. Other relevant history. Ask about other features that would support the diagnosis of SLE, Fig 8. Skin rashes, especially ones that are photosensitive. Raynaud's syndrome. Myalgia. Neurological abnormalities, seizures or psychiatric disturbances. History of spontaneous abortion. Drugs, some, e.g. hydralazine, can precipitate a lupus-like illness. Examination. Once again, it is important to make an initial assessment as to how ill the patient is, but the details given here do not indicate that the patient is in extremis. Examination, as always, should be focused on confirming or refuting diagnoses suggested by the history, so apart from checking vital signs, look for the following. Signs of PE and deep venous thrombosis. Raised JVP, palpable right ventricle, loud P2, right ventricular gallop, pleural rub, and pleural effusion. Warm swollen leg. Check pulse oximetry. Signs of pericarditis/pericardial fluid. Pericardial rub. Raised JVP and/or pulsus paradoxus, fall in systolic BP of more than 10 mmHg on inspiration, if there is sufficient pericardial fluid to cause hemodynamic compromise. Signs suggesting SLE. Skin, typically facial butterfly rash and/or alopecia, also livedo reticularis. Fingers and toes, are there signs of ischemia caused by severe Raynaud's phenomenon? Joints, are these swollen or tender? Small joints are typically involved in SLE in a symmetrical and, usually, non-deforming manner. Cardiovascular, cardiac murmurs and peripheral edema. Neurological, including ocular fundi. Neuropsychiatric lupus can present in a wide variety of ways: cranial nerve palsy, peripheral neuropathy, cerebrovascular accident, movement disorder, and transverse myelitis. Investigations. Exclusion of PE. Although it seems very likely that this woman has lupus, it would be unwise to completely dismiss PE on clinical grounds. A normal D-dimer would be reassuring, but an abnormal result, which would be very likely in the case described and almost certainly be nonspecific, should be followed by appropriate imaging, either lung ventilation perfusion scanning or CT pulmonary angiography. Urinalysis. Around 10% of adults presenting with lupus have protein or blood in their urine, which indicates renal involvement. Proteinuria should be quantified, most usually by measurement of urinary albumin/creatinine ratio. Red cell casts confirm active glomerulonephritis. Biochemistry. Check renal function, to ensure no further acute deterioration in this case, and liver blood tests. Lupus can affect any organ, but liver involvement is unusual. Patients may have low serum albumin as a result of proteinuria and/or chronic disease. NB. Renal involvement is common in SLE but does not cause symptoms, so it is very important to perform urinalysis, measure serum creatinine and estimated glomerular filtration rate. Hematology. Check FBC, blood film, reticulocyte count, direct antiglobulin test, Coombs test, clotting screen, and haptoglobins. Lupus often causes anemia, which is usually normochromic and normocytic but can be hemolytic. Hemolysis is suggested by polychromasia, reticulocytosis, low haptoglobin levels and a raised unconjugated plasma bilirubin. A positive Coombs test would suggest autoimmune hemolysis. The presence of fragmented red blood cells on the blood film would indicate a microangiopathic process, as can be seen in SLE, Fig 9. Up to 2/3 of lupus patients have leukopenia, with the main deficit being lymphopenia. There may also be mild thrombocytopenia. This contrasts with the primary systemic vasculitides, which usually cause high white cell and platelet counts. Abnormalities of the clotting screen may be associated with antiphospholipid antibodies. Inflammatory and serological markers. Check erythrocyte sedimentation rate, ESR/C-reactive protein, CRP, antinuclear antibodies, anti-double-stranded DNA, dsDNA, antibodies and complement levels. The typical pattern of active lupus is a raised ESR with a low CRP, low levels of complement C3 and C4, antinuclear antibodies and antibodies to dsDNA. There may be other autoantibodies, especially antiphospholipid antibodies such as the lupus anticoagulants, which prolong the kaolin-cephalin clotting time but paradoxically predispose to thrombosis. Other investigations. Renal ultrasonography to confirm that the patient has 2 anatomically normal kidneys. Renal biopsy to make a precise renal diagnosis to determine prognosis and inform treatment decisions. Management. The management of lupus is complex and depends on the precise clinical situation. Agents used for renal disease include steroids and cytotoxic drugs, principally azathioprine, mycophenolate mofetil, and cyclophosphamide. There is recent interest in the anti-B-cell monoclonal antibody rituximab. The renal response to treatment depends on the histological appearances, e.g. lupus membranous nephropathy is not usually treated aggressively because it responds less well. Studies from the U.S. National Institutes of Health have shown benefit from steroid therapy in patients with severe diffuse proliferative lupus glomerulonephritis, Fig 10, with the benefit increased if pulsed intravenous cyclophosphamide is added every 1 to 3 months. Plasma exchange offered no additional benefit. Cyclophosphamide toxicity includes hemorrhagic cystitis, infection, bone marrow suppression, suppression of ovarian function and tumors. The use of tumor captoethane sulfonate, MESNA, helps protect against bladder toxicity. Drug toxicity should be discussed with the patient and, when practicable, storage of gametes should be considered before therapy is started. Treatment of BP is important. Dialysis and/or renal transplantation may be required if the kidneys fail completely. Further comments. Joint pains, pleuritic chest pain and renal abnormalities should always raise the possibility of lupus. Renal involvement in lupus is important and all patients with lupus should have their BP monitored, together with urine dipsych analysis and serum creatinine measurement. Lupus is unpredictable, it can remit and relapse frequently. It can be a mere nuisance or it can be a devastating illness. This is worrying for patients, uncertainty is difficult for them, their family and friends, and also for their doctors. Many of the treatments used are of limited efficacy and have side effects. All these issues need to be frankly discussed with the patient at the beginning. With women, discuss the interplay between pregnancy and lupus, and hypertension or renal impairment if present. Lupus can be exacerbated during pregnancy and for the first 2 months postpartum, and women with lupus have an increased incidence of abortion, perinatal death, and preterm delivery.